Boluses of intravenous 0.9% saline are administered and an infusion of insulin is initiated. 3 hours later, the patient becomes somnolent and develops a headache. She has had 1 episode of emesis and 1 episode of incontinence. Her urine output has been 30 milliliters per hour. Results of follow-up serum laboratory studies are shown. What is the most appropriate intravenous pharmacotherapy? Please insert your answer into the chat. Thanks for your answers. Now we'll reveal our red flags. Let me ask our panelists if you want to weigh in about your thought process as you read this and other things you might be concerned about as you look at some of these red flags here.
Her somnolence and the headache with the emesis, all of which are worrisome because we just loaded her with fluids, and she was hyponatremic before, and now I guess when we're learning about it in school, they say low to high and the pons will die. So we're worried about like osmotic demyelination syndrome. And also some of her other labs look like they're leveling out a little more, so we can probably go less aggressive. And that's why I was thinking the IV potassium would be important, but also either slowing our fluid boluses or giving her something slightly more hypertonic than 0.9 if she's having these cranial symptoms.
Great points. Ben?
For me, this was a classic case of, in a 2-part question, reading the first one and then guessing what the second question will be, and then going down the wrong track as a result of it. Because I totally went down you're pumping the person full of fluids, you're giving them insulin, you need to watch potassium. And in retrospect, after slowing down a little bit, I should have expected to see cardiac complications from potassium, not neurologic. And in my mind, when I saw the 0.9 saline, I said, okay, they're getting neurotonic fluids, you should see a correction. And it kind of just scrubbed away the low sodium that we'd seen before and honestly just forgot about it. And so I think it's a good example as a reminder for me of like, when you see a question, you do need to verify your assumptions prior to going in and prior to selecting and choosing an answer.
It didn't look so low that I would expect to see catastrophic neurological effects. And additionally, I wasn't that concerned about pontine demyelination syndrome because it's rising actually relatively slowly for an acute correction of hyponatremia. And so I think that's where this question sort of got me, was that I perhaps was overthinking it or sort of confused, like, would this really be a clinical presentation for someone with this lab value? And I don't know how the test writers sort of approach that, but that's definitely something that has gotten me before on many other NBME questions as well, in terms of, okay, there's evidence that points towards one thing, but then there's one thing in my mind that doesn't quite fit with that picture. And so it becomes tricky.
Thanks for those comments. I will tell you, I think Dr. Rebbecchi and I both read a case like this and struggle because it's a sick kid. You've done an intervention and they're getting sicker. And this, even in a test setting, and I can feel this as we interact, that this is making you all really uncomfortable too, because this girl is getting more and more critically ill. It goes back to some of the realism I think that a lot of our writers try to put into these questions. And as Ben had said earlier, you have some preconceived notions when you start unfolding that case. You start thinking about what they're going to ask, and then sometimes you have to reset a little bit. Thank you for all of your answers. And now we'll show you the option set. And it's the same lead-in. Which of the following is the most appropriate intravenous pharmacotherapy? And the answer choices are A, bicarbonate, B, dexamethasone, C, 50% dextrose, D, furosemide, or E, mannitol. Please insert your answers into the poll. So everybody's answers have been entered into the poll. Now let us reveal the correct answer. Correct answer is E, mannitol. I want to ask our panelists first, how does your approach to this question change with an option set in front of you as opposed to not having it? And in terms of coming up with the right answer, right intervention?
I think right off the bat, we can see that the option choices aren't so much concerned with her electrolyte status per se, but are more looking at volume status and location of volume. The bicarb speaks a little bit to her acid-base status, although we can see that that's been improving. So it does give you a sense of how to direct your energy as you're reading the question and what exactly you should be looking at in terms of the labs.
It definitely helps keep you on the rails. So I think Ben and I have kind of discussed how sometimes when you start reading the question, you get lots of ideas, maybe you get off track. But when you have a distinct answer set in front of you, that really does sort of put you into a specific sort of frame of mind or limits your choices, which can help you if you happen to be sort of thinking of something else. And then when I see these answer choices, it's immediately like, oh, of course. When I see mannitol, I'm like, of course, this person has neurological complications. They obviously have cerebral edema. I don't need to worry about their sodium right now. I was already sort of questioning that, which had the answer choices not been there, I would have chosen the wrong answer.
The first thing I do when I see an answer set is I get out my right click and I start nixing answers. Another thing I do when I approach an answer set like this, especially with drugs, is I ask myself this question: what is this medication treating? And in some cases, what is the duration of action of this medication? So given this, it seems like it's a fairly acute scenario. While a steroid may be indicated, it's not going to act most quickly enough to be the most appropriate immediate next IV medication. So that one will be gone. Kind of the same thing with furosemide. There are other ways to correct an electrolyte abnormalities. Furosemide, she's having kidney output. I don't think it's like a congestive heart failure picture. We don't need to get lots of fluids off of her. Which then you come down to the bicarbs, the dextrose, the mannitol. And of those three, the one that really caught my eye with this question set was mannitol, because with the preconceived notions that we talked about previously, mannitol wasn't something I was considering. And when I see a red herring question like that, it generally puts up a little stop sign to say, what would you give mannitol for? And is there a reason why it's listed? And so that would kind of put up the brakes of, let's just not nix it off because it doesn't make sense, but this would be given for cerebral pressure. Do I see any reason that there could be cerebral pressure in this vignette?
Would you have answered this differently, or would it have been a harder question if E was instead hypertonic normal saline or 3% saline instead of mannitol?
I think it would have been a slightly bigger jump. Like Ben was saying, mannitol is something where you see it and, well, as far as we've been tested, like that just screams, like elevated intracranial pressure. But for a more hypertonic saline, I'd have to remember, wait, normal is 0.9%. Like, when do I actually give this? When is it actually relevant? Like, I think it'd just be more steps.
In an open-ended question, you'd have a whole list of things. You'd probably do 10 things all at once on this patient, right? And so it's a matter of deciding in that instance, what are you going to do first, or what's going to be most important? And that's one of the reasons we have to have an option set for exams, questions like this, because they are nuanced and they're rich clinically, but we also want it to be fair to the people taking the test, that they know where to focus their answering, or what part of their knowledge we're asking them to demonstrate.